Hello everyone, today we'll be talking about ventilation perfusion mismatch, also called VQ mismatch. This is the last reason for hypoxemic hypoxia in our series of lecture. So what is VQ mismatch? VQ ratio is the ratio of ventilation to perfusion. If you have increased ventilation or a decreased perfusion to an alveoli, your VQ ratio will increase. Here the perfusion decreases but never reaches 0, because if it reaches 0, this area would be a dead space. If your ventilation drops and perfusion increases, the VQ ratio drops. Here the ventilation decreases but again does not reach 0, because if it reaches 0, it will be a shunt. So let's look at the alveolar concentration of oxygen and carbon dioxide as you go along this fold path where you have a complete shunt, that means VQ of 0, to a complete dead space with VQ ratio of infinity. In a dead space, since there is no oxygen and CO2 exchange, the alveolar and CO2 concentration, they match the inhaled air. So your PO2 is 150 and your PCO2 is 0. As your VQ ratio decreases, some of the oxygen exchange and carbon dioxide exchange occur and your CO2 rises and your P alveolar O2 falls down. In a normal alveoli, the P alveolar is around 100 and P alveolar CO2 is around 40. As your VQ ratio decreases further, your P alveolar drops further and your PCO2 increases. And by the end, when you reach VQ of 0, there is no ventilation to this area, but there is still perfusion. So your O2 and CO2 will match the O2 and CO2 of the mixed venous blood. This is a complete shunt. So let's understand the VQ ratio in a more intuitive way. So we have an alveoli and we have a blood flow through the alveoli, and these blue dots represent oxygen molecule. So the concentration of oxygen in the alveoli will depend upon how quickly the oxygen is replenished from outside, and it also depends upon how quickly the oxygen is washed out of these alveoli through the capillaries. So you can already see that the alveolar concentration of oxygen will be directly proportional to the ventilation, and it will be inversely proportional to the perfusion because it is removing the oxygen away. So your P alveolar O2 is nothing but a constant into ventilation by perfusion, and at equilibrium, or rate of the oxygen coming through from ventilation equals the rate of removal of oxygen through the capillaries. So the P alveolar depends on the VQ ratio. So let's look at some of these numbers and see how we derived them. So we know that the partial pressure of oxygen in the air is 150 and the CO2 is 0. And in the venous side, the partial pressure of oxygen are 40 and those of carbon dioxide are around 45. At a ventilation of around 4 liters per minute and a perfusion, which is cardiac output of 5 liters per minute, will give you P alveolar O2 of around 100 and P alveolar CO2 around 40. And we already know that the diffusion of oxygen from the alveoli to the capillaries is pretty fast. So the PaO2 and CO2 in the arterial blood will be equal to that in the alveoli. If there's a shunt, the V is equal to 0. So the oxygen concentration in the alveoli will depend upon the PaO2, because after some time these two are going to equilibrate. So P alveolar O2 will be equal to 40 and P alveolar CO2 will be 45. If there is some ventilation, there will be more oxygen molecules in the alveoli, so the P alveolar O2 would be higher than the PaO2. For example, in this case, it's around 50, but as the ventilation increases, that means as the VQ ratio increases, the P alveolar O2 would increase, and similarly the P alveolar CO2 would decrease. This should be 50. If there's a dead space, that means there is no perfusion, Q is equals 0. The P alveolar O2 will equilibrate with partial pressure of oxygen in the air, because the oxygen can come in, but it cannot really go out anywhere. So after a couple of breaths, the partial pressure of oxygen in the alveoli will mirror that of air. If there is some perfusion, you see that some of the oxygen will be removed through the capillaries by diffusion, and thus the partial pressure of the oxygen in the alveoli are going to drop down a little bit. Here the P alveolar or O2 is around 130, and as the amount of flow increases, this is going to drop even further. VQ mismatch is the commonest reason for hypoxemia. The average VQ ratio of lungs can be calculated by total ventilation divided by total perfusion, which is around 4 liters per minute of ventilation divided by 5 liters per minute of cardiac output, which comes to around 0.8. Let's understand some regional differences in ventilation first. So if you remember the pressure volume loop, these are your intrapleural pressures and these are the volumes. After end expiration, the intrapleural pressure is around minus 2.5 centimeter of water at the bases and around minus 10 centimeter of water at the apex. The differences arise because of the gravity. An alveoli at the base, when you inhale, you decrease your intrapleural pressure, say 2 to 3 centimeter, and the volume will increase. This is your change in volume. However, the alveoli at the top, it's already quite stretched out. So with the same amount of pressure, the increase in volume is much smaller. And the reason this happens is because on the top, you already have negative 10 centimeter of water pressure, which is stretching out this alveoli versus much smaller stretch on these alveoli at the bases. So when you inhale, the volume increase in the basal alveoli is much higher than the one at the apex. So your ventilation increases from upper region to lower regions. If you look under microscope, you will find that the alveoli at the apex of the lungs are much larger than ones at the bases. The ventilation is around 1/3 at the top as compared to the bottom. The distribution of ventilation is much better when lying on the sides, or even better if you're supine. And these differences occur because of the gravity. When you're lying down, that means your height of the lungs drops down by quite a bit, so your ventilation is much more evenly matched. There's also higher ventilation in the central regions as compared to the peripheral regions. And the facts that we just talked about holds true only for normal respirations. If you're using high flows or you're dyspneic, the ventilation actually increases more on the top as compared to bottom. Right ventricle is a weaker part of the heart and is unable to generate very high pressures. Average PA pressure runs around 20/10, that's your systolic and diastolic. And the height of the lungs is around 25 centimeter in an average person. So there are areas at the top of the lungs which are not really perfused. In middle, there are areas which are perfused during systole but not during diastole, and the bases get perfusion both during systole and diastole. And we talked about that most of the oxygenation happens in zone 3. So the perfusion also increases from upper to lower regions. So as we saw, the perfusion is higher at bases when upright. However, it depends upon the lung volumes. At total lung capacity, the blood flow at the bases is much higher than at apex. However, as the lung volumes decrease, this changes. So at FRC, you can see the blood flow is more uniform, and at residual volume, the blood flow is actually lower in the bottom as compared to the apex. This happens because the pulmonary resistance changes with lung volumes. In an alveoli, we have intra-alveolar vessels. That is the part of the capillaries that runs through the alveoli, and there are extra-alveolar vessels which are outside the alveoli. And both of these see different pressures when the lung volumes change. So at total lung capacity, the alveoli are overstretched and they squish the intra-alveolar vessels, thus increasing the resistance in this area. However, your extra-alveolar vessels are quite nice and open because of the more negative intrapleural pressures. As your lung volumes decrease, the intra-alveolar vessels open up and the resistance in this part decreases while the extraalveolar vessels are still open. So your resistance becomes minimum at certain lung volume. As the lung volumes decreases, for example at residual volume, you are forcefully exhaling, your pressure in the pleura is more positive, so your extraalveolar vessels are squished, so the resistance starts increasing again. Perfusion is certainly gravity dependent and also depends on the lung volumes, as we just talked about. There are higher numbers of alveoli at bases when compared to upper lobes. This is another reason why perfusion is higher in the bases. Because of more alveoli, there are more capillaries in the area. Also, there are 30% higher number of alveoli in posterior lungs when compared to anterior part of the lungs. There is a greater blood flow through the central part of the lungs when compared to the peripheral parts. During proning, the blood flow through the different part of the lungs become more uniform. Let's make a graph of P alveolar O2 with P alveolar CO2. You remember that these partial pressures, they depend upon the relative perfusion and ventilation in an alveoli. On one side, we have a complete shunt where your P alveolar O2 is around 40, which is equal to the mixed venous blood with a VQ of 0. On the other extreme end is a complete dead space where your P alveolar is 150 and your VQ ratio is infinite. In the center, there is a VQ ratio of 1, which is a perfectly matched ventilation and perfusion. At the base of the lungs, the VQ ratio is around 0.6, and at the apex, it's around 3. There are different VQ ratios at different heights, depending on the ventilation and perfusion. This is a very interesting figure, so let's take some time understanding this. This is the apex of the lungs, and this is the base of the lungs. These are the rib numbers. At the apex, the volume in a slice of lung is around 7% of the total, and you can see the ventilation is pretty small as compared to the bottom. It's around 3 to 4 times lower. However, the perfusion is much smaller when compared to the bases. So the VQ ratio, when you divide, you get 3.3. So this is the VQ ratio at the apex, and 0.6 is the VQ ratio at the base. If you look at the P alveolar O2, since you are tending towards a dead space physiology, your P alveolar O2 is much higher when you compare to the bases. So your P alveolar O2 is 89. The concentration of oxygen is pretty much similar, though slightly higher in the apex compared to the bases, because we know that P alveoli is pretty high. However, the perfusion is pretty small, so your oxygen content coming from the apex is pretty small when compared to the bases. The VQ ratio is around 1 at the level of the third rib. Things to note, the discussion that we talked about are valid only for person at rest, and these numbers change as you exercise or as different lung pathologies come into play. That's your apex of the lungs, and this is your base of the lungs. The VQ ratio is much higher in apex as compared to base when you are upright. However, if you are in prone or supine position, the VQ ratio is pretty much similar throughout. We will stop here for now, and in the next session we'll talk about why VQ mismatch causes hypoxia and what are the various clinical features of VQ mismatch and how we can treat these patients. Thank you.